Okay, so good afternoon, and thank everyone for joining us. I would like to thank everyone who is attending. This webinar is Food Sensory, addressing feeding issues in the disability community. I am pleased to introduce Wallace Johnson, who is assisting me today. He will be providing us with information on Lacan before we get started with our webinar. Go ahead, Wallace.
Okay, thank you, China. And like China said, I'm going to talk briefly about Lacan. And what this is it's called Lacan stands for Louisiana Council's Advocacy Network. So this is a program from the Louisiana Developmental Disabilities Council, and it's a grassroots advocacy network. What it does, it links lawmakers, individuals with disabilities, and family members to make positive change in systems serving people with disabilities. The Lacan also advocates for policies and systems that support inclusion everywhere, where people learn, work, live, and play. And the Lacan also advocates for systems that support children and adults with disabilities to live in their own homes and be fully included and participating members of their local schools and communities. Lacan leaders also provide a connection with a regional team of advocates to provide information on proposed policy changes and how those changes may affect you and others. And they also provide training in skills to effectively advocate for system change and support you to link you with policymakers. So if you're attending this webinar from another region outside of the Southwest Louisiana area and you want to be linked up with your Lacan leader in your area where you live, then you could contact Some Families of Southwest Louisiana and we'll connect you with your Lacan leader. The website for Lacan is simply www.lacanadvocates.org. And you could go there and find out all kinds of information about the Louisiana Council's advocacy network known as Lacan. And one of the things that we have coming up in Southwest Louisiana, we have a webinar coming up on Thursday, January the 22nd from 10 to 11. And this is the Lacan membership Families Helping Families Advocacy Training webinar. So the purpose of this is to do advocacy training and also give you a chance where you can meet other advocates for people with disabilities, learn more about Lacan's advocacy efforts, and then pick up on some tips on how to advocate on a state level. And so again, this webinar, the Lacan membership FHF advocacy training, webinar is going to be January the 22nd from 10 to 11, and it'll be on Zoom. And so we'll send you information out about that at the end of this webinar. I'll send you an email where you'll get this PowerPoint of that our presenter is going to present today. Jeannie Dees, we're grateful she's here. And then you'll get some links of upcoming activities, and then you'll get a link where you can find out information about Lacan. And thank you, China, for letting me talk about Lacan. And so now I'll turn it back over to you so you can have Jenny Dees do the wonderful presentation.
Thank you so much, Wallace. I do appreciate it. Okay, so today we are pleased to welcome Miss Jenny Dees, a very special guest from Lake Charles. Jenny is also an occupational therapist with Therapy Works. Today she will be sharing her expert opinion on feeding issues. Please present your questions in the chat box and we will try and answer those throughout the webinar. Wallace is also assisting me and will be sending out the PowerPoint, the survey links, along with the certificates at the end of this webinar. With that said, I ask that you give your full attention to Ms. Jenny Dees and help me welcoming her to this platform. Ms. Jenny?
Thank you,
Thank
China.
you.
Okay, so I'm not very technologically awesome, and so all I can see is just like y'all, my PowerPoint. So if there are questions in the chat box, if someone could help me out by letting me know, or if like the camera does something funky, because I don't have a clue what the camera sees at the moment.
Would it help you if I ran your PowerPoint so that way
It's
you
okay.
can see
We
the
got it
notes
set
you
up like
made?
this. So just let me know.
Okay, because I can definitely load it, and then you could that way you can see what you need to see.
That's okay. We'll be good.
I'll be
Okay.
checking the chat.
Perfect. Thank you.
Okay.
Okay. So, well, now there we go. So a little bit about me. I am an occupational therapist. I've been one for about 10 years now, and I'm also recently became the owner of Therapy Works, Southwest Louisiana. I specialize in infant and child feeding, as well as sensory integration and early childhood development. And I have 4 kids, and I've been on both sides of the fence. 2 of my kids have special needs and feeding difficulties and all sorts of stuff. So I have been through it both as the parent and as the therapist. So I think that kind of gives me a unique perspective in working with some of these kiddos. So why I got started in feeding therapy was these 2 little ones right here. So my oldest child was 1 year old when I started occupational therapy school, and I always knew he was a little different. And then I started learning all this stuff. I'm like, oh, well, that makes sense. So he would only eat chicken nuggets and mac and cheese, like every kid under the sun, except literally nothing else. I tried asking teachers for help. I tried asking other therapists, and no one could really give me answers. So it was a lot of trial and error with him. And you know what? Eventually we figured it out. And now he is 13. And if I push, he will eat a pretty good diet. And then my 3rd child was born. And I realized that parents need a whole lot more help than just muddling through it on their own. She had tongue ties. She had airway issues. She had multiple surgeries, texture issues. But we finally got it figured out with some help. Okay, so today we're going to cover a couple common feeding misconceptions, as well as tell you what feeding therapy is, help to figure out if you have just a picky eater or truly a problem feeder. And then once we know that, we can figure out where to go from there as far as treating. And we're also going to do a little bit on helping with self-feeding, because I know that can be a problem for some of our little ones as well. Okay, so everyone always says that when a child is hungry enough, they will eat, that they're not going to starve themselves. That is wrong. I have seen 30-pound 8-year-olds because they refuse to eat anything but the inside of unfrosted Pop-Tarts. That was the only thing this little boy would eat. There are children that the brain perceives the food as a threat. And so if it does not feel safe to them, they are not going to eat it no matter what you do. Some other common things is that a child is going to outgrow being a picky eater. Sometimes this is true, but not always. And personally, I'd rather not wait 10 years and see what's going to happen. And another one that I hear all the time that parents tell me is that it's their fault because they kept making the child a special meal. That is definitely not true. As a parent, you have done everything you can to figure out how to get your child to eat in some way, shape, or form, and you just haven't had the help to know what to do next. Okay, so feeding therapy is a specialized form of therapy. It can be done with pretty much anyone that helps us have a healthier relationship with food. Typically, it's done by speech or occupational therapists, kind of just depending on who has the training needed in the specific clinic. However, ABA also can do some feeding therapy within their programs. And a lot of times we have to involve a bunch of specialists to figure out what's going on, whether it be the nutritionist to make sure we're getting all the vitamins and minerals we need, GI for G-tube, psychiatry for anxiety. Do we have tonsils and adenoids that are in the way? Are our teeth not working? And even counseling and play therapy to help us work through some of that anxiety, especially if it's a child that is not a candidate for medication to help with that. And the thing that bothers me the most is that they really don't teach feeding therapy in any professional school. They brush on it for about 2 seconds and then you're kind of left on your own. So it requires you to go out and get training on your own to really do the best job that you can. So this is just a list that I found online of everyone that can benefit from feeding therapy. Our focus today is going to be young children who are picky eaters or problem feeders. A lot of times these are children who have autism or sensory processing disorder as well. And we're going to touch on the chewing and swallowing difficulties, because that can often contribute to the sensory difficulties that kids have with food. But as you can see, there's a lot of people that could benefit. I don't know if any of y'all are interested in learning about like G-tube transitioning. It's kind of a specialized thing that is more going to take more time than we have in today's presentation. But if anyone has a specific interest in that, they can always reach out to me and we can talk from there. Okay. Everyone has seen these picky eater tests on Facebook, wherever, and you give yourself a point for everything you won't eat. Funny thing is, I don't think I'll eat about 3/4 of the things on this list. I am actually a feeding therapist who needs feeding therapy. And I had a significant tongue tie until I had it fixed back in July. I had it revised, and chewing got a whole lot easier, but unfortunately, I still don't like a lot of these foods. So how do we know if our child is just picky or a problem feeder? So we look at a couple different ways. A picky eater is going to have a pretty good variety of foods. They may not like your chicken, or they may not like broccoli, but you can get at least a vegetable in there. There's a meat in there, a couple things like that. Whereas a problem feeder is going to have less than 20 foods in their repertoire. That includes things like goldfish, Cheez-Its, all those snack type foods. Those all count towards the number of foods eaten. The other thing that we look for is food jags. Food jag is when you've eaten something for a long time and this was your favorite, and now all of a sudden the kid is like, I'm never going to eat that again. Well, when that happens, if the child is just a picky eater, typically they're going to replace that food with something else. And then if we give them a little bit of a break, they're going to eat it again. A problem feeder, more likely than not, will not begin eating that food again without significant help. And a lot of times they don't replace that food with something else. So if they had 7 foods to begin with, now we have 6. And that's a big problem. When you present new foods, for our picky eaters, they may tolerate it, they may try it, they may turn away, but they're not going to have a complete meltdown, shutdown, anxiety, running from the room kind of reaction that we see with our problem feeders. We also have to look at the texture of foods and like where they belong in that food pyramid. Problem feeders, typically most of their foods fall into one texture category or one like food group, whereas picky eaters will usually have some scattered all throughout. The other thing that I see very, very commonly with my problem feeders is that they cannot be in the same room as other family members when they're eating or cooking. The sight or the smell of someone else's food that is not a preferred food for them is enough to make them not want to eat at all. And that can be really disruptive for meal times when families are trying to have a nice family meal and you have one person that can't be with you because they can't look at what's on your plate. I love this graphic because people ask all the time, why does it matter? Well, if you pull out a thing of blueberries, one's juicy, one's sweet, one's sour, one's hard. If you pull out a thing of Cheez-Its, they're the exact same thing every single time. Before you ever put it in your mouth, you know exactly how it's going to feel, how it's going to taste. And that comfort in knowing what's coming next is what a lot of our problem feeders crave, and why these other foods can be so scary to them. So when we look at helping our problem feeders, first we have to figure out what the problem is. In feeding therapy, we're just going to go over some of the most common ones that I see, but I want to look at the motor skills, the sensory processing skills, and also the oral structures that are involved with feeding. And we're going to continue going over this slide throughout the next part. So when I look at motor skills, the first thing I look at is positioning and strength. And then I'm going to look at their chewing patterns. And then I'm going to look at their swallowing characteristics. Now, as an occupational therapist, my scope of practice allows me to treat within the mouth. However, once the food moves from the mouth to the throat in the actual swallow, that becomes more of a thing for speech therapists to treat. OTs typically do not have the training required for that. So when I say swallow, I'm not looking at it down the throat. I'm looking at more of symptoms after the fact. Do we have residue in our mouth and there's still food pieces all over it? Or after we swallow, do I notice, we're coughing or we sound wet? Are we obviously choking? Things like that. So, and this is just a brief, we're going to go into each of these a little bit more detail, but this is a brief for the sensory processing skills. Most of the time, we see kids that fall as either hyposensitive or hypersensitive. The hyposensitive kids are the kids that don't, basically, their sensory receptors don't feel the food enough. So you're going to see kids that overstuff their mouth like crazy. They're going to put the entire chicken nugget in their mouth, and that's how they're going to eat everything. Also, they typically don't tend to chew their food well enough. They're just going to swallow it before they ever chew, or they continue putting more in while they're still chewing. A lot of times, these kids are also what I call our oral seekers. So they like to put everything under the sun in their mouth well beyond a developmentally appropriate age. The hypersensitive kids are what you typically see as like a picky eater. They want things to be a certain texture or a certain temperature or to taste a certain way. They're the ones who can't eat with their family members. A lot of times these kids are what people call like little neat freaks. If something gets on their hands and face, they don't want it on there. They freak out. They're going to want to wash their hands right away. And that all plays together. They also tend to have a lot of anxiety regarding food. More so than some of our other kids that have feeding issues of just like motor skills or being or the hyposensitive. In feeding, we have more than just taste involved. We have the tactile system, which tells us how the food feels. We have how it smells. We have how it tastes, and we even have the auditory system. I've had several kids tell me that they don't like a food because they don't like the way that it sounds in their mouth. Would have never thought about that before, but now it makes sense. The other thing that we see with sensory skills when they're causing an issue is a hypersensitive gag reflex. And these are the ones that, if they put something new in their mouth, they're going to gag and vomit at least some of the time. And then oral structures. So the oral structures involved in feeding, we need to take a brief, quick check on these just to make sure that they're not getting in the way of the skills we're wanting to teach. So teeth, make sure, first off, do we have enough teeth to chew? Because some of our littles, if they're still under 2, they don't have molars yet. And so it's kind of hard to chew some of those foods. But we also want to look and make sure, alignment. Are they meeting each other so we can chew? TOTS, which is tethered oral tissue. Now, this area is an area of contention among lots of practitioners, but I always check and make sure that the tongue has enough mobility to move the food inside the mouth. Because some kids, the tongue cannot move enough, and when the food gets on the tongue, it stays there because it can't go anywhere else. Tonsils and adenoids is another big one. Adenoids you cannot see by looking in the mouth. ENTs see them with I don't really know how ENTs see them other than in surgery, but I know that enlarged adenoids can cause issues with congestion and breathing. And then tonsils that are too big can sometimes make it feel like the airway is blocked and that you're choking. My oldest son, he actually had what was called kissing tonsils. So the tonsils were so enlarged that they were touching in the back, and that was causing him to have issues swallowing, which was why he only wanted to eat certain easy foods. We also want to look at airway. Is the child able to breathe through their nose, or do they have to have their mouth open to breathe? Because if they have to have their mouth open to breathe, then obviously that's going to affect our ability to chew and swallow. Looking at if the child snores or is frequently congested, that can give you some clues that airway isn't quite where we want it to be. Any issues that you might suspect in one of these structural things need to be brought up to your pediatrician or dentist or ENT so that the appropriate referrals can be made, because these kind of things really do require a specialist who has a lot of training in the field to assess them. But we need to make sure that the child has the structural abilities to do what we're asking. So we kind of looked at and we've done our little screen. We figured out, do we have motor problems? Do we have sensory problems? Do we have structural problems? Do we have all the above? But now that we know where the problem lies, what are we going to do about it? So this is where we're going to spend probably most of our time during this presentation. So the most important rules of feeding therapy. Now, these I came up with on my own, but they are my top priorities. And the biggest one is that feeding therapy has to be child-led to an extent. Our job is to push the child to just right past where they are now. But if we push too hard, we are going to see them take 3 steps backwards. It's rooted in anxiety. Feeding therapy can be very, very anxiety provoking for children, because, I mean, the mouth is kind of like a scary place. You see it at the dentist all the time with these little kids. They don't want anything or anyone near their mouth. So we have to make them feel safe. And that's done a lot through play and building rapport with the child. If it's your own child, then you already have that rapport. But if you're a practitioner treating someone else, then you have to make sure that you take the time to have that good relationship before you ever start introducing feeding into a feeding therapy. Feeding therapy progress is 99.999% of the time going to be very, very slow. But that's just how it is, because if we push too much, we're going to go backwards. So we celebrate the inch stones, not just the milestones. Safety is always the top priority. So safety, we need to make sure that there is good head control so that we don't compromise swallowing and accidentally end up with something going down the wrong way and into the airways. That can be done, if the child can sit on their own, great. If they have good head control, great. If not, we need to make sure that we have a high chair or a tomato chair or some way to give them that support they need in an upright position. A car seat is not my favorite for this because they tend to be angled too far, even though they have that little bit of an upward angle, they're too horizontal for a safe swallow. So just make sure we've checked all of that before we ever start feeding. The other thing is kids are going to gag and they will vomit. I keep a little bowl next to them at all times, and they know that bowl, if they feel like they're going to throw up, they throw up in the bowl, and then we just empty out the bowl, get a new bowl, move on. If they want to spit something out, that's fine. Go ahead and spit it out. Thanks for putting it in your mouth. Spit it out in your bowl. So I call it like my no thank you bowl, and that's always with me. The other thing is we always want to end therapy sessions on a good positive note. So if you had an episode of gagging or vomiting with something, we want to make sure that we find out a way, even if we have to go backwards a little bit and do a skill that the child's already mastered, we want to make sure we end on that good note so that the brain perceives it as a pleasurable experience. Okay, so we're going to now... So if we identified a problem area as our motor skills, we're going to look at some things we can do to help that. So positioning and strength. We talked about the positioning, that we need to have that good head control for the swallow. This little guy is in what's called a trip trap chair. They are super crazy expensive, but I'd love to own one day. They're awesome. But what we really want for positioning is we want to make sure the head is supported, and we want there to be 90-90-90. So the hips bent at 90 degrees, the knees at 90 degrees, and the ankles at 90 degrees. We also want to make sure their feet are supported, because when your feet are supported on a surface, you feel grounded. Think about if you're sitting at a bar and you're on a high stool and there's no rungs to put your feet on. Your feet are kind of just dangling there if you're short like me, and it's really hard to concentrate on a lot of different things when you don't know where your body is and you feel like you're going to fall off. I also like to use a 5-point harness. That's the one with the chest straps and the buckle at the bottom for kids that have low core strength, because I do not want them to be concentrating so much on what's going on in their mouth that they forget about their core and they fall forward, and then we risk a compromised swallow and things going the wrong way. So don't be afraid to use those harnesses longer than you think you need it. Like I said, safety is my number one concern in all aspects, and it doesn't really hurt them to be strapped in. Once you have good positioning, you also need to work on making sure that they do build up the core strength that they can position themselves. So playing in tummy time, even for our big kids, is a great thing. Have them lay on their belly on the floor and color. Lay on their belly on the floor and look way up in the sky at the TV if you're watching a movie. Play a board game laying on the floor. Just play with toys laying on the floor on your tummy. Anything we can do to build that strength in extension, which is where our back is straight, is going to be what we need to get that core strong enough for them to be able to hold themselves up for feeding. And then the head control, we already talked about that, either through positioning or that core strengthening will increase that neck strength too. Okay, so we've got positioning down. Now we are going to look at chewing patterns. I think I didn't go over chewing patterns before, but there's 3 different chewing patterns. The first is called a vertical chew, or like a munch chew. So that's where babies go up and down with their teeth, and that's it. That is the first chewing pattern. Some people call it mashing. And it works great for the purees. It works great for when we're really steaming all those apples and carrots and stuff and cutting them into little pieces before they have teeth, because the gums can just mash it. But that's not going to work very well as we expand our diet and go into harder to chew foods. So the next thing that we see is called a diagonal chew, and it's where the mouth kind of closes and goes to the side a little bit. And that is the closing, so you get the mashing, but that diagonal slide also gets a little bit of grinding in there. So typically you start seeing that before 1 year of age, but if it's something we don't see, then we need to teach them. The most mature chewing pattern is a rotary style chew. So that is like where your mouth makes literally a circle. And that is the hardest chewing pattern, but that's the one that we need to process things like raw, crunchy carrots or meats, or especially like something like a steak or a grilled chicken breast, things like that. Just think about how much chewing it takes to eat a piece of steak versus a banana. So if we are using the same chewing method on the banana and the steak obviously is never going to get chewed up. So we need to teach that. And there's a couple different ways that I like to use. So I use that little tool that you see is a Z-Vibe. It vibrates. Some kids love the vibration. Some kids don't. You can use something that vibrates, like a vibrating toothbrush, or I put links at the end of this to the Z-Vibe and the Talk Tool Sensi and things like that. But at the end of the day, you can really just use some food too. So the side bites progression. What we want to start with is something the child likes. So goldfish, Cheerio, whatever, something little and bite size, and you're going to place it on one side of the child's mouth, and they chew that and eat it, and then you put one on the other side, and then one side, then the other side, then one side, then the other side. And what that's doing, it's teaching their brain that, hey, I have to go the side to side way. After they get comfortable with that, then we're going to move into like long stick shapes food that it takes a little bit to chew. So, like a Slim Jim, something like that. You could like roll up a fruit by the foot if they like fruity things, and make like it into a stick. Sorry, guys. And what they're going to do is they're going to hold one side of their mouth, hold it and chew 3 to 5 times. And then they'll move it to the other side and hold it and chew 3 to 5 times. For these longer foods, you can hold on to it or the child can hold on to it. It's kind of like whatever the child's tolerance is. And then the last stage of this side progressions that we see is where we do finger prompts. So what we'll have the child do is they'll have something in their mouth and we'll tap with our fingers on which cheek it needs to go to. Now, depending on the age of the child you're working with, they may not understand this process yet, but you do what you can. If we can get them doing it with the long stick shaped foods and they're really young to 1.5 to 2.5 kind of stuff, that's usually good enough that they kind of start picking it up on their own. Now, if you have a child that is not comfortable doing it with food, you can do it with things like this is a bite block. I use it to keep kids from biting me. I put it between their teeth, but you can do it with things like this, or you can get like a chewy tube and they can chew on the chewy tube, kind of whatever you can find. So that is a great way to teach, especially for younger kids. The pattern chewing practice I really love to do with 3 and up that have a little bit more understanding, but sometimes every once in a while you get a 2-year-old that can get this too. But what you want them to do is learn how to chew with all the different teeth in their mouth. And that's going to teach their mouth to move in that circle shape. So something long and stick shape. Veggie straws are a really good one for this. And I'll put it by their back teeth, then their canines, incisors, canines, back teeth, and then repeat. And we just do it like that. So they're taking bites in each location, and then they chew it up and swallow it. The other trick that I have for kids that, they don't really understand the side bites progression or the pattern chewing, I use these little mesh teething bags, and I put something in here that doesn't dissolve that they like. So like fruit snacks, most kids love fruit snacks, or, if they like steak works really good too, apple slices. And what they have to do is, if they just do like this on the teething bag, nothing will come out. So they learn that if I do this and then I slide, hey, stuff's coming out through these little holes. So that is a good way to do it as well. And then I've also done it with like chewy tubes or teether straws. And what I do is I shove food in the little holes, and then they chew on it like kind of like a dog toy to get the food out. Okay. So swallowing. So this is just like effectively swallowing the food so that we aren't at increased risk of choking because there's food in our mouth that we didn't think was going to be there. So a lot of times with this really young age group, it takes us helping to regulate this. They just don't have the self-control yet, but it never hurts to start this. So mirror checks is one thing you can do. You see this little guy has his mirror. And so, you chew the food up. Okay, let's open our mouth and let's look and see. I know it sounds gross, but feeding therapy is kind of gross sometimes. So you look in the mouth. Is the food in a ball or is it spread all out? If it's spread all out, oh, we're not ready to swallow yet. We need to chew and use our tongue to move it back together some more. Okay, let's look again. Oh, now it's in a ball. Now I can swallow. Or you can do it after you swallow. So your child chews and swallows. Open your mouth, stick out your tongue. Oh, there's goldfish still all over my tongue. Something wasn't right. So that is a strategy that I use. Again, it's kind of hard with this 0 to 3 kind of age group, but in the older kids, it works really well. With young kids, it's a lot of compensatory. So I am watching as we're eating, do I see anything in the cheek? If there's something in the cheek, I'm going to kind of rub on that cheek a little bit to get them to move it to their mouth, center of their mouth to swallow. Or I'm going to watch in their mouth. Do I see any residue? And if I do, okay, let's take a drink of our milk or our water or whatever, and let's clear that before we keep going. If in eating or drinking, you notice frequent coughing or like not gagging, but real choking is a big, big no-no. Frequent coughing, or they sound wet, that needs to be brought up to your pediatrician for further evaluation to make sure that when they're swallowing, it is going down the correct way and not into the airways. When I do feeding therapy sessions, I do not require like a swallow study test to check swallow before coming. In some cases I will, but in most cases I don't. But if I notice that we're very wet sounding after feeds, or we're coughing a lot, things like that, I will pause feeding therapy until we have discussed with the pediatrician whether or not we need a swallow study and have gotten the results of that if indicated. Okay. So if the problem is in sensory processing skills, let's see what we do. So the hyposensitivity, obviously this kid does not care about his spaghetti everywhere. But for kids that don't feel things as much, we need to increase that arousal level. So kind of wake up those sensory receptors. So for these guys, we tend to do vibration before feeding. Now, for vibration, if a child has seizures, vibration in the mouth can be contraindicated or could possibly cause seizures. So you need to have clearance from the doctor before doing vibration in the mouth if there's a history of seizures. I've never actually had it trigger anything, but just to be on the safe side, I always want to get that clearance. So with my little Z-Vibe, I do a couple different things. So first I do cheek circles. So I take it, I go inside their mouth, and I just do circles, like 5 little circles on the insides of their cheeks. The other thing you can do if they tolerate it, some of them don't like this, but you can do what's called a tongue drag. So like if this was the tongue You're going to take the Z-Vibe and put it towards the back of their tongue, and you're just going to slowly drag it out for like the count of 3 to 5. Then we do that like 5 or so times, and then we put it in our mouth and we hold it with our lips closed. Not with our teeth, though. We want to use our lips and our lip strength, and we're just going to hold it in there and count to, depending on the kid, sometimes it's 10, sometimes it's 20. It just kind of depends on the kid. But that helps all those receptors to wake up and get ready to know that there's food in the mouth. Another thing that you can do, and I do it a lot with feeding kids, is called the Beauregard brushing protocol. I do a modified version, and I have a picture of that at the end. This technically should be done under the guidance of an occupational therapist, but it uses a cradle cap brush, and it involves brushing on the arms, legs, hands, feet, and back, followed by squeezing the joints together. I call them squishies, on the arms and legs to help the whole body sensory system wake up. Heavy work is also great for these guys. There's a link at the end of the PowerPoint as to heavy work activities that can be like frequently done at home. But basically, it's any activity that like compresses joints together to help the brain know where those joints are. We use these a lot for our hyperactive kids too, because it kind of helps them calm down. But for our kids that are not as sensitive, it can help wake them up. So whole body, have them push the laundry basket with clothes from the laundry room to the kitchen before they get in their chair. Have them jump up and down 5 times before they get in their chair. With the mouth, crunchy foods like carrots or chewy foods like fruit snacks or gummies, those are great for the brain noticing where the mouth is. Chewy tubes like the red T-tube are also really good for that. So if we do those before we eat, it decreases our chance of overstuffing due to not feeling it. These are also, like I said, the oral seekers. So a lot of times we do these same techniques every hour to 2 hours, depending on the kid, during the day to help decrease the putting of toys and non-safe things in the mouth. And a lot of parents see really good results with that. Okay, so the hypersensitive kids are the ones that feel things way too much. So I have one guy, he's a teenager, and he's very, very, very orally hypersensitive. He tells me everything tastes sour. Even sweet things taste sour to him. Like we tried an apple, and it was actually a sweet apple. I tested it, and it was sour because his brain perceived it so much that it moved from that sweet to sour category. So the funny thing is, vibration, those can help calm down the sensory receptors for the hypersensitive kids in the same way it helps wake up the receptors for the hyposensitive kids. I don't really know how it does two opposite things in different kids, but it does. I'm sure some really smart person somewhere knows how, though. So we do the same thing with these, the cheek circles, the tongue drag, and the holding, but I also do what's called 1, 2, 3 taps. A lot of time, for these hypersensitive kids, they cannot tolerate that tongue drag at first because frequently these kids also have a hypersensitive gag reflex. So on my 1, 2, 3 taps, it's kind of a modified version getting into that. So if this is my tongue and this is the front, I'll start. Sometimes I use vibration. Sometimes I have to start with just a tool or a piece of food. And we're just going to do tap, 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 tap. You can count, you can sing, whatever, and do that a few times. As they get used to this really up close, then you go a little bit further back. So tap, 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 tap. And you slowly can make your way further back on the tongue to desensitize it and desensitize that gag reflex at the same time. You can also work on, at first, it can be really quick taps. So tap, tap, tap. Then it can get to longer. So tap, tap, tap. So you're putting a little bit of pressure down on each one too. And you can even add the tongue drag at the end when you get to the end of it. You have to be careful with these kids because they tend to have high anxiety. And so we need to make sure that we're respecting their boundaries. The Beauregard brushing protocol is great with this as well. And then the next 3 are we're going to go over them in the next slides. So tactile desensitization in feeding therapy is super important because if I'm not going to touch something with my hands, there is no way I'm putting that in my mouth. So a lot of times the first thing we work on is desensitizing the hands and around the mouth first. So I love messy play. Kinetic sand, shaving cream, Orbeez, paint, mud, whatever you want to do. Rice is another good one. I mix rice and pasta sometimes for the rice and pasta in a big dish for kids that don't like that wet feel because it's two different textures and feels. So it's a good bridge activity. If the kid really is resistant, put it inside of a Ziploc bag first and let them play with it through the bag. Or if they want to wear some little gloves, I'll let them wear some little gloves at first and get used to it. And then we'll slowly work on getting closer. So, if we've worked up out of the Ziploc bag, we're out of the gloves, but we still don't want to touch it. Okay, let's dig with a spoon in it because every once in a while that your hand is going to touch whatever you're digging in. I like to bury toys in there. We bury lots of animals, things like that. And then we have to dig and, first we're going to dig like this and then we're going to dig like this and then we're going to really get in there. But we want to encourage them to interact more and more with whatever tactile medium we're using at not necessarily their own pace, but at just a little bit of a push, not too much. Some kids really like a timer to know, hey, I'm going to do this for 5 minutes and then I'm done. For kids that, like how I said, the rice and the pasta, sometimes I'll start out with 3/4 rice and 1/4 pasta. Sometimes I'll start out with half and half. It just kind of depends on what the kid needs. But the other thing, whenever we're playing with textures, I always have baby wipes or a sink nearby so that if they need to wipe their hands, they can. I don't want them to become overly anxious because this is supposed to be a fun experience for desensitizing it so that we can get to the mouth later. Now, I'm going to encourage them, hey, can we wait another minute? But at the end of the day, if they absolutely have to, we will, and then we'll go back. Messy play with food is also a really big one. I know it's a pain in the butt, but we live in the South. A lot of times you can just throw them in a baby pool outside and let them play. It's really important, especially for our little ones that are under 2. Food chaining is the main thing that we do in feeding therapy. So it is slowly introducing new foods that have a similar aspect to one the child already eats. So I've got two examples up here. So let's say that the kid loves fruit snacks and you want to try and get them to eat real fruit like a strawberry. So what we're going to do is we're going to start with that fruit snack and we're going to slowly change it in one way at a time until we get to what we want. So we'll take the fruit snack and then we might move to a fruit leather. A fruit leather is going to require more chewing and be a little bit of a different texture than a fruit snack. Okay, we mastered that. Let's add some freeze-dried strawberry crumbs on top of our fruit leather. We changed the texture again, and we got 2 textures because in a real strawberry, you have the texture of the seed and the texture of the fruit. So now we've got that. When we get that, maybe we try just the freeze-dried strawberries because that is a much stronger flavor. And we're already kind of used to the texture, but it lets us get there. And then, small, thin strawberry slices. And I usually pat them dry because a lot of kids don't like the wet. So we are changing. We went from the shape of the freeze-dried strawberry and the flavor to the same shape, the same flavor, but it's slightly wetter. It's dried, but it's still slightly wetter. And then we can move to strawberry slices and then the whole strawberry. The seeds are always the hardest part on those dang strawberries. And then like a grilled cheese sandwich, moving up to chicken breast. You start with your grilled cheese. So we're going to change one thing. Let's add a little bit of deli meat chicken. And by a little bit, I mean like I'll break off a piece and I start out with like a crumb of the deli meat chicken and then slowly move that up to where we can get like a slice of deli meat chicken in there. But even a crumb, some of them can notice. It's really kind of crazy. And then, we could try, let's take the bread away. We still have our cheese and our meat, but we don't have the bread. And then we can work our way up to removing the cheese, and now we have chicken breast. Texture progression is kind of within food chaining, but there's also another way that I work it. I use this a lot with my little ones that are under 3. My older ones, this doesn't tend to work well because they're a little too smart. I can't bribe them. I can't encourage them. I'm I'm not trying to trick them, but I am hiding things a little bit from them. So, like one kid right now, he loves Cheerios, and we're working on getting some meat in his diet. So we said chicken nuggets. So what I've actually been doing is I took a Cheerio and I took the skin of the chicken nugget and shoved it in the hole of the Cheerio, and then I covered it up with my fingers. So I put it in his mouth. And I mean, he spit out the first few, but then eventually we mastered that. So then I took the meat in the center because the meat is a different texture than the skin and did the same thing. And we mastered that. Then I did them together. And now we're at the point and like slowly worked up. Now we're at the point where the chicken nugget piece is bigger than the Cheerio piece. But for him, if he sees the chicken nugget without the Cheerio, he won't eat it. So we're still working on it. But from there, what I'd want to do is start doing chicken nugget and Cheerios side by side, and then just the chicken nugget. With this slow texture progression, I always allow the child to spit it out if they need to, because if I force them to hold it into their mouth, it is going to create anxiety and it is going to take steps backwards. That's why I have that bowl. You know, with each spit out, with each time they spit it out, it was one more exposure in their mouth, which got them one step closer to the end goal, is how I look at it. So the fact that they spit it out and didn't throw up, hey, that's a great win. Okay, so the hyperactive gag reflex. The gag reflex when you're born is very far forward on your tongue, and it moves back as you start to chew on things. Well, kids that don't chew on things, it doesn't move back. So we actually talked, I think we kind of talked about all these already. Yeah, how to move it back when we talked about the hypersensitive kids. But something to note is kids that have that hyperactive gag reflex, if you're doing a feeding session and they gag and vomit, a lot of times they will be more sensitive following that. So just keep that in mind, that we may have been working on, you know, the big chicken nugget with the Cheerio, but now we vomited. And so now we have to back up to where the Cheerio is bigger than the chicken nugget and slowly progress back to where we were. I see it a lot. It just stays kind of hypersensitive for a little bit. So just keep that in mind and don't get discouraged. Okay, the last thing is those oral structures. So kids can actually go to the dentist as young as 12 to 15 months, and they are the best ones to assess those teeth. So I always refer to them. As far as tethered oral tissue, as I said, there's lots of controversy surrounding that right now. I don't really care what it's called at the end of the day, but I want to know the things I want to look for. Can the child move the food adequately? Most doctors assess for tongue ties by, hey, can your kids stick their tongue out of their mouth? That's actually the least important thing when it comes to eating. I don't know about you, but I never stick my tongue out like that when I'm eating. So I want to look, can they move their tongue from one side to the other, and not just the tip, but the whole tongue to move that food? Can the back of the tongue reach that top of the mouth so when we're swallowing, it clears the food? And can the tip of the tongue elevate to the top of the mouth? If we can do those things, we probably have enough movement to get done what we need to do. Tonsils and adenoids, your pediatrician is the best one to look at that. But if the tonsils at the back of the mouth look huge, chances are it could be impacting how your child swallows. Also, if they have frequent ear infections, cough, allergies, all that kind of stuff, it makes it hard to breathe. It makes it hard to eat. Snoring is another big one. And open mouth breathing and drooling. Though snoring, open mouth breathing, and drooling are three things that can indicate the airway isn't quite as good as it should. Okay, so some tips for choosing the new foods when you're doing feeding therapy. If the child is able to help, let them. Let them choose one thing and you choose one thing. We also want to look at all the sensory aspects of the food. So not just the taste, the smell, and the look. We want to think about how it feels on our fingers. Is it slimy, wet, dry? What about in our mouth? Is it crunchy? Is it chewy? Does the food all stay together, or does it fall apart when I go to chew it? Because some kids don't like it when it scatters all over like pieces of rice. Does it require us to have that mature chewing pattern, or can we get by with mashing? Some kids color bugs them. There's the orange food group. And we want to find what our child likes and play into that when we're choosing new foods. Okay. Anxiety is another big thing in feeding therapy. So we want to find some ways to work around it. Every exposure the child has to food helps to decrease that anxiety. So helping cook, helping clean, helping grocery shop, helping wash vegetables, things like that. That's all important for feeding therapy. And I frequently assign that as homework. The other one I really love is having kids clean other people's plates. So they can take their mom's plate from the dinner table and go dump it in the trash can. If you can get them to wipe it off with their hands and then wash their hands, even better. This kiss, lick, shark bite, bite and spit, that is my favorite progression. So whenever we're introducing a new food to make it less anxiety provoking, we kiss it, we lick it, we do a shark bite, which is where you take it and they bite it with their teeth and then leave their little teeth marks in it. They think it's really funny. And then we'll bite off a piece, or I'll put a piece in their mouth and they'll spit it out. Then we go to bite it off, chew it 3 times and spit it out. And then we do bite it, chew it 5 times, spit it out, and on and on. And then eventually we get to bite, chew, and swallow. Each little step is a big deal. Reinforcers are the way to go. They don't have to be edible. I have the kids pick a game, and for every we kiss it, yay, here's a piece to your game. You lick it, hey, cool, here's purple crayon. Why don't you color some purple now? These mesh and silicone feeding bags, and I do have links to both of these. Not quite the same one, silicone, but similar, are my favorite for the hypersensitive kids because it provides a sense of security. If they know they can hold it, it's not coming out of this bag, they're more likely to do something. And the biggest thing, one of my biggest things is I do not accept the words yuck, gross, yum for kids that have the verbal abilities. I want to know why. Okay, great. I'm glad it's yuck. It's okay if it's yucky. Why is it yucky? Is it the taste? Is it the feel? Great. I'm glad it's yummy. Is it the temperature? Is it the crunchiness? I want to know what you're feeling so that your brain is processing what you're doing. No, ma'am. Sorry, my kids just got home from school. So that your brain is processing what you're doing so that you have one more level of experience with the food. And finally is choices. You want the child to be able to have a part in their therapy because when they feel like they're taking part, they take ownership, they take pride, and it's going to go better. Okay, self-feeding real fast. We push for losing the bottles because drinking from a bottle promotes what's called a tongue thrust and sucking, which is what we don't want to do when we're feeding. We want our tongue to go back and we want to chew. Ideally, we want to take the bottles away by 12 months, but you know, those comfort bottles at bedtime and nap time, those are a pain to take away. So at least daytime ones. Don't ever put baby food or thickeners into your bottle. It promotes improper oral patterns and is actually an increased risk for aspiration. Go ahead and start giving those little babies utensils. Let them practice with their food and let them practice and play. And also, straw drinking can actually start as young as 6 months. Most babies aren't ready till closer to 9, but we can start practicing. These little honey bear cups, I love them. They're silicone. I can squeeze them. And so the child puts it in their mouth and I squeeze it. Oh, there's liquid. Then they suck. So it's a good teaching tool. Okay. So this is just some key things. Safety is always our first priority, both physical safety and the child feeling safe. It should never feel stressful. And if you can do it with peers, positive peer pressure is great. Finally, every kid is different. These are things that I find to work with the majority of children. However, there's always the exception to the rule. And so if you're struggling, reach out to a pediatrician or a therapist for some more help. Okay, so these next few slides are just some links. I don't know if they're going to share the PowerPoint later, but they're links for y'all to have to some of the products that I really like to use, and like this Beauregard brushing protocol and stuff. So yeah, that's all I got. Anyone have any questions or anything? Sorry if you hear my chaos crew in the background.
Okay, so I did answer a few questions throughout the PowerPoint.
Okay.
but it was basically like, this is some good information. Will we get the PowerPoint? So I did answer a lot of those
Okay.
throughout. And I did inform them that they would be getting the PowerPoint.
Mm-hmm.
I don't really see anything else as far as like any other questions. Do y'all have any other questions for her before we end the webinar? If so, please ask. Here is one. Is there an ideal age to start feeding therapy?
I always want to start before there is a problem. So if you have a concern, it's not going to hurt to use some of these techniques, even if there isn't a true problem. So if you're concerned, go ahead and give it a shot. I will say the hardest age group to work with is probably the upper 4 through 8 year olds because they know everything. They don't want to hear anything and they don't want to participate sometimes. But yeah, besides that, really you can always just give it a shot.
Okay. Any other questions? Can you speak to the training ABA therapists have about this?
So honestly, I cannot to I have typically the feeding courses that I have taken are not offered to ABA therapists. I do not know what training they have. I just know that several ABA centers in my area do work on feeding with their children.
Okay. The next one says, thank you, very informative presentation. Give tips to use for oral sensitive dental patients, both children and adults.
Are in dental, I'm assuming in dental office.
That was great tips. It was great tips.
Oh,
Yeah,
Great
great
tips.
tips. Yeah,
okay.
great tips.
Yeah. Hopefully it helps.
Yeah. Thank you. Let's see. Definitely want the PowerPoint if possible. So yes,
Oh
we
yeah.
will be sending the PowerPoint out.
I don't know how to do that, but go ahead, y'all.
Yeah.
Sorry.
All right. Let's see. Thank you. This was great. Great information. Thank you. Thank you. All right. So I guess that's it. Any other questions? Thank you. Great information. Very useful with our 0 to 3 population.
Well,
So
good.
very good.
That's the bulk of my caseload.
All right. Well, thank y'all so much. We really do appreciate y'all taking the time out to visit with us today. So, like I said, we will be sending out the PowerPoint. I would appreciate if y'all would take the time out to do the survey link. We will be sending out certificates as well. I hope to see y'all on our next webinar. If y'all are interested, we do have a listing of a few of our webinars. Wallace will also send that out to y'all. We do have a listing on our Facebook page. This webinar was recorded. We will have this linked up on our YouTube channel as well. It will be up in the next couple of days. Wallace usually have that up in like a maybe like about a week. It should be up. So I thank y'all so much for participating with us, and y'all enjoy your week. Okay. All right.
Okay, thank y'all.
Thank y'all so much. Y'all enjoy the rest of your afternoon.
The YouTube channel will be a link in what I send in the follow-up email.
Okay. He will have the link for y'all. Thank y'all.
But it'll take me a couple of days to get the presentation up, like China said.
Yeah. Yeah. I usually always tell them about a week to give it about a week. Okay. Thank y'all. Thank you, Jenny. I really and truly do appreciate you always taking the
Right.
time out to help.
Anytime. I appreciate it.
All right, honey. Enjoy your day, okay?
Y'all too.
Okay, bye-bye.